we have the pleasure of having Dr. Sturgeon here with us. Briefly, he's the chief of endocrine surgery at Northwestern University's Feinberg School of Medicine in Chicago. He specializes in thyroid cancer, hyperparathyroidism, adrenal tumors, including pheochromocytomas and adrenal cancers, and his clinical focus is treatment of thyroid cancer and thyroid and parathyroid disease, and he has a special interest in multiple endocrine neoplasia. Without further ado, Dr. Sturgeon, you can...
Hey, thanks, Bridget. Yeah, almost everything I do is thyroid related nowadays. Thyroid cancer, thyroid nodules, goiters, whatever. Some of it is parathyroid as well. So I feel like this will be right in the wheelhouse that I usually run in. Thanks to ThyCa for the invitation to talk to you guys today about recurrence. I have no disclosures I put up here that I don't have any financial disclosures. These are, however, my relationships with professional groups that you can see here. I mean, the real disclosure or bias is that I am a surgeon, so I spend my days operating on people, so you may see a little bit of a slant there. We're running behind on the schedule, so I put this slide in basically to say what we're not going to talk about today, so we'll go fast to go through those. And then these are the key points that we're going to hit in this topic, or sorry, in this talk. So we'll start out with some demographics. This is from 2019, the data that you see here, based out of the SEER data set. So it's a few years old, 2019, so a few years have passed. There's about 1 million people in the United States who are living with a history of thyroid cancer. About 75% are women, 25% are men. The age breakdown is kind of interesting. About a third of the patients are over the age of 65, and a third are between 50 and 64 in that 14-year bracket right there. Younger than 50 is our smallest group, 240,000 of the total there. So this is kind of an interesting breakdown that I think is evolving over time as the US population ages. And we're more successful at treating the cancer, by the way. I want to start out with a global treatment strategy for thyroid cancers and to point out that there's a name change coming from the World Health Organization, what we used to call Hürthle cell carcinoma, slowly going to be replaced with oncocytic carcinoma of the thyroid, or OCA. It seems kind of hard to make that transition, but I'm going to try to do it in this talk. As I think we all know, the first step is thyroid cancer with an appropriate lymph node clearance. Some people get radioactive iodine, fewer and fewer nowadays, and TSH suppression is step 3. Surveillance is kind of what we're going to talk about today, because during surveillance is when we get a chance to see if there's a recurrence or not, and we'll be talking about what you do if you find that. Typically, 3 possible ways that can go. The surveillance should be most intense in the first 5 years. And if there's no recurrence during that time period, most people should be referred for clinical follow-up. For situations where there's a clinically significant recurrence detected, in general, we resect resectable disease and we consider radioiodine, especially if it hasn't been done before. For unresectable recurrence, it becomes a little bit more complicated. Again, what that means is there is no surgical remedy for it. So external beam therapy, systemic therapy, and nowadays also I think percutaneous therapies like RFA and ethanol are going to come into play too. For medullary, very similar except for no radioactive iodine and no TSH suppression. And the therapies for recurrence look very similar as well: resecting resectable disease, systemic therapy, and external beam. 5-year survivals are very good, but if you break them down based on the cell type of origin, then that helps you a little bit distinguish the different types of thyroid cancer. As you can see, for localized disease, for papillary, follicular, and medullary, the survival for 5 years is essentially 100%. And even the combined groups are very, very high. For regional spread of disease, papillary, 99% 5-year survival. When you get to patients with distant spread with papillary, it drops down to 75%. Follicular, 63% at 5 years. Medullary, 40% for distant spread. So the farther ahead that the cancer's gotten, the greater morbidity that we see from that. Anaplastic is an entirely different situation where you see a 5-year survival of only 34% for people with localized disease and single-digit survival for patients with regional or distant spread, 7 overall. So that was 5 years. Let's look at 10-year data in SEER. And I'm just going to draw your attention to this trend here. In order to have 10-year survival, that means we've got to go back 10 years to look at people who were diagnosed 10 years ago. So that's why you see that the year is 2009 at the end of this study. So starting at the year 2000, people diagnosed then had a 10-year relative survival of 95.6%. Fast forward a couple of years, 96%, then 97%, and 97.8%. And then in 2009, it was 98%. This is all comers, all types of thyroid cancer, all ages, all stages, 10-year survival of 98%. So that those are people diagnosed in 2009. So what about people diagnosed in 2022? I would expect it's even better than this. It should be even closer to 100% 10-year survival, because that's the trend that we've seen over the last 20 years. So let's talk about recurrence a little bit. I think the key thing to remember is that recurrence is probably a misnomer. It's probably persistence that we're really treating. People ask the question, I was cancer-free, how can the cancer come back? And I think it can be disheartening. But really, it probably is just a persistence. It's probably due to the fact that there were a small number of cancer cells that escaped the other treatments that were given. And over the course of time, it became apparent that there was still some cancer there based on very, very sensitive imaging studies or tumor markers, for example. 3 types of recurrence: local, regional, and distant. Local essentially means in the thyroid bed or maybe in the thyroid lobe that wasn't taken out, if that's the case. Regional spread is lymph nodes in the neck, and distant spread is outside the neck, like lungs, for example. How often does this occur? This is one of our key questions I wanted to answer for today. For papillary, you can see it's about 5% at 5 years, 10% at 10 years, and 15% at 25 years. For follicular, it's 18% at 10 years and 21% at 20 years. And medullary is greater than half of all patients at 10 years. The data here that I'm quoting on the bottom, some of these are kind of old studies, right? 2007, 2002, 1996. It's because if you want to know what a 40-year recurrence rate is, you got to go back quite a ways. So looking at these long-term data recurrences is something that you got to have many years of data to try to figure it out. Here's another old study, one that I was a senior author on, where we looked at 52,000 patients with just papillary cancer. And we asked the question, what is the relationship between the size of the tumor at the time of diagnosis and the recurrence rate? And you can see that as the tumors are larger and larger, that recurrence rate is rising as well. So for the smallest tumors, those that are 1 to 4 centimeters, that would be this group here, your recurrence rate is between 7 and 11%. Once you get above 4 to 8, it's 17, and greater than 8 for those largest tumors that we found were about 1 in 4. So there seems to be a very clear relationship between the size of the tumor at the time of diagnosis and the chance that it's going to recur. The smaller, the better. What about extent of surgery? Recurrence between having a total thyroidectomy and a lobectomy is not a huge difference. It's about 2%. And I think people have pointed more towards the biology of disease than the extent of surgery in order to influence things. We know that survival is not statistically significant in the most recent studies, but there's not much done actually on recurrence and extent of surgery that's in a large data set like this. So maybe there's a small difference, but I think you have to tailor the amount of surgery to the how much cancer there is at the time of diagnosis, and that's always the right thing to do. If you look at survival, everything I just showed you a moment ago was recurrence data. This is like whether people are alive or not alive at 10 years. You can see there really is no way to distinguish survival differences up to 3 centimeters. So from 0 to 3 centimeters, survival is basically exactly the same. And this is up to 4 centimeters, and statistically, there's no difference here between these numbers and these. Something small is going on here, obviously, but not statistically different. There is, of course, the statistically lower survival if you have a larger tumor at the time of diagnosis, whether it's 4 to 8 or greater than 8. The extent of surgery, this difference here is not statistically significant. It's about 2% again. So the risk factors that I just showed you and a few others, tumor size larger is worse. If there's local tumor extension like extrathyroidal extension or extranodal extension, it's worse. Positive margins, certain subtypes that are thought to be more aggressive, less extensive surgery when it needed to be more extensive, a non-suppressed TSH, failure to give radioactive iodine when it really should have been done. I'm not saying all the time failure, just some people need it and they should get it. A lot of people don't need it. And then if there's clinically positive nodal metastases in general, that at the time of the diagnosis, that's a risk factor alone for recurrence. Well, why did I show you a bunch of recurrence rates that are in the high 20s, maybe in some cases, but mortality rates that are in the single digits, like 2%? And probably the reason is that, like I said before, metastases discovered during follow-up are probably just persistent disease that survived the initial treatment and super slow growing. And when we detect it and treat it, then patients can go on with their lives. And we think that an earlier detection and treatment of recurrences like these may improve your survivorship. We don't think it changes the length of time for survival, but it may improve the quality of the time that's there because you don't have cancer creating a problem for you in the neck, like invading something like the esophagus or something like that. It affects the ability to swallow. So metastases that are discovered during follow-up, they're probably persistent disease, especially if it's been a long time since surgery. You got to think, okay, that's really slow growing. And I got to keep that in mind when we think about how we're going to treat it. We no longer call cancer cured. This is from 2015 ATA. So they're trying to shift to this new terminology, and for better or for worse. Essentially what they're saying is the definition of excellent response to therapy is that there's no clinical evidence of a cancer. So on palpation or the patient doesn't feel anything. There's no sensation, there's something wrong, whatever. In addition to that, there's no imaging evidence of tumor. More and more, this is moving towards neck ultrasound as being the defining characteristic, but also includes radioiodine, and then very low serum thyroglobulin levels during TSH suppression or after stimulation. And of course, that means that there's no interfering antibodies. So we're testing in a way that we're actually testing TGs. So those three things are true, then we would have called that cure in the past, but now we're calling it excellent response to therapy. Next key question, where might thyroid cancer spread to? All of these things are possibilities. Liver is favored by medullary thyroid cancer, but all of these things are areas where thyroid cancer has been shown to spread. Lymph nodes are kind of the main thing. Cervical lymph node metastases are actually quite common for papillary. Depends on how hard the pathologists look under the microscope, but maybe 2/3 or up to 80% of papillary patients are found to have some microscopic disease in the lymph nodes. And then how much cancers in the lymph nodes definitely influences your risk of recurrence. So if there's microscopic cancer, it's about 4%, but if there's macroscopic, like big, bulky lymph nodes, then it's up to 1/3 of patients. And large nodal metastases, like I just mentioned, a large number of them, or extranodal extension, these are all risk factors for recurrence. This is from an old paper, but still is helpful, I think, in thinking about dichotomizing patients into two groups, those that have less than 5 metastatic nodes and those that have more than 5. It seems to be a threshold there. If you look at just the less than 5, the recurrence rate is about 4%, 2%. If once you get up to 5, the recurrence rate jumps up to about 20%, and it's higher for those patients that have bulky nodes or extranodal extension. We do screening by physical exam, ultrasound, blood tests, including TG and anti-TG and TSH for papillary, follicular, and oncocytic cancers, and calcitonin CA for medullaries. Radioiodine scans are done less and less often these days, but still done. PET scans are being done quite a bit, actually more than the last time I gave this talk. And we're thinking that they're actually more helpful than they used to be for differentiated thyroid cancer. DOTATATE scans, I'll show you an example of that, are really excellent for medullary thyroid cancer. It used to be, we didn't have great screening, but now we have DOTATATE, which is really fantastic. So physical exam is really not good at diagnosing small amounts of cancer in most circumstances, but we still do it. We must do it. We have to identify those people that have the bulky cancers that are fixed. That's a more significant disease, a more aggressive presentation. So we're definitely examining patients looking for that stuff. Ultrasound is the best imaging study that there is for thyroid cancer. And this is what ultrasound will help us with. You can see here with the red arrows, this white line in the center of the lymph node is evidence of a benign lymph node, a normal lymph node. So usually lymph nodes are elongated and flattened and have a white line down the middle of it. Here's an example where there's no line. And that brings up suspicion for thyroid cancer being within the lymph node. This line, incidentally, that you see like here at the left lower panel represents the artery, vein, and lymphatic that run through the middle of the lymph node that you see in the cartoon. That is something you can see on ultrasound when it's a normal lymph node, and when it gets clogged up full of cancer, you can't see it. So that's the distinction there. Cystification is really clearly outlined here at the end of this lymph node, this black area, and also this one here. This is evidence of there being fluid formed within a lymph node that's always abnormal, and patient has a history of that's a metastatic cancer until proven otherwise. Microcalcifications are seen in a number of images here. This is also macrocalcification with a shadow behind it. And these are pretty classic signs of a metastatic thyroid cancer. And you can see this jugular vein here is being deviated as well. And that's another sign that this is an abnormal mass that's in the area. Abnormal lymph nodes are typically circular, like perfectly round, like this one you see here and this one here. Like I said, normal nodes are flattened and elongated. If the node is like a perfect circle or perfect ball, then that's very suspicious for cancer. And as I also mentioned before, any cystic formation, and this is a lymph node that's got lots of cysts in it, that's a cancer until proven otherwise. CT scans can be very helpful for identifying metastatic spread, like to lymph nodes in areas that ultrasound has a hard time looking at. But for the lateral neck, like I showed in this is an arrow pointing to a lymph node in the lateral neck. I think ultrasound is even better. Here's an ultrasound of the exact same lymph node that I just showed you in the other screen with the yellow arrow on it. You can see there's a lot more information here about, exactly where that lymph node is located, how deep it is, what it's next to. And this is a Doppler box that we're looking at here, where you see all this bright color. And this is a very typical chaotic blood flow pattern that you see in metastatic nodes. And the way that this node abuts right up against the jugular vein makes me concerned that there could be invasion. I don't get that out of the CAT scan. So I think that CAT scan is great, but it doesn't give me this level of information. This is what CAT scans are really good for. You cannot possibly see this metastatic disease in the chest with a CT scan. A CT scan cannot, or sorry, with an ultrasound. Ultrasound cannot get through bone to see something like this. So if your clinical presentation is very advanced, or you suspect aerodigestive tract invasion or disease that goes into the superior mediastinum like this, you have to use cross-sectional imaging to try to find it. How about the nuclear medicine stuff? This is what radioiodine scanning looks like. It's pretty fuzzy, as you can tell. There's not a great anatomic detail here. This is kind of what we've been looking at with I-131 for many years, trying to determine where the hot spots are in the body, and then doing CAT scans around those hot spots. By the way, this is a basically normal scan with uptake just seen in the GI tract and in the bladder and salivary glands. This is an example of DOTATATE PET for medullary thyroid cancer. The really bright things that you see here are all medullary cancer deposits. There's even one in the bone here. And this is a really outstanding imaging modality to show you exactly where the medullary cancer is. And also you can do these 3D renderings where you can see, you can spin the image 360 degrees and try to understand the anterior posterior relationships and relationships to other organs and things. So I think that DOTATATE has really advanced our ability to monitor or identify medullary thyroid cancer, and I think it's really very helpful. Tumor markers, we do look at doubling time, specifically calcitonin CEA from medullary. And the thing to remember is not this formula where you need the natural log and stuff like that, but the fact that a long doubling time is a good thing and a short doubling time is a bad thing. If if doubling time is very short, then that's typically a marker of progressive disease. And for a long doubling time, stable disease, as you can see in the graphs that I put here. There is some debate about what's short and long, and anything that's over 2 years is clearly long, and anything that's less than 6 months is clearly short. But in between is an in between. So all I can say basically is that you want to shoot for the longest doubling time. Hopefully that's what we get when we're monitoring people. If we see the doubling time is starting to shorten up, or if the doubling time is very short, in general, we think of that as a more aggressive situation, which merits more aggressive treatment. I don't have natural log function on my calculator, so I just go to the internet and I do calculations from the American Thyroid Association web page. You can do this yourself also to try to figure out the doubling times for calcitonin and CEA for medullary cancer. It's also being looked at for differentiated thyroid cancers like papillary. Same relationship exists where the shorter the doubling time, the more aggressive the cancers. This is a meta-analysis of a bunch of studies looking at that phenomenon. They have had mixed results because in some cases it seems to be more meaningful than in others. I would just chalk this up to there being much more heterogeneity in thyroglobulin, and or the fact that thyroglobulin is very much indexed to the TSH, which really is almost impossible to standardize in these tests. So when do you screen for thyroid cancer recurrence? So now that you've had surgery and you've recovered from it, you should have a physical exam at 6 months, 1 year. And then it depends. Hopefully for most people it's annually, but it could be every 6 months. I do tend to hold on to people pretty closely and examine them every 6 months unless I see negative tumor markers, and then I might let it go out to a year at a time. Ultrasound, same thing, every 6 to 12 months for a while, and then periodically once we think the disease is stable. TG, anti-TG, frankly, to get a good doubling time on any of these things, you need about 2 years of data every 6 months, and a longer amount of time every 6 months is even better. And radioiodine scans should probably be for high-risk patients, not for low-risk patients. So if your original tumor was low risk and the TG is undetectable and the ultrasound doesn't show anything, that's generally not the situation that we're doing radioiodine for. We used to do it for everybody, and now we're thinking that it should be more for patients who have high-risk disease and that we know is radioiodine avid. I think another key question is, what do we do about cancer recurrence? And it depends on how much cancer there is, like what the tumor burden is. You know, is there a lot of cancer that's still in there? Is a very, very tiny amount? Knowing how fast it's growing, like I just showed you with doubling times, is also very important. The aggressivity, you know, is it a more aggressive subtype? Where it's located, I think, is key. If it were like the tip of your fingertip or something, it really can't get into anything important, but it's right next to your esophagus or your voice box, a little bit of growth might be a problem. So where it's anatomically located, I think, has to be considered. Hey, what's been done in the past, you know, and how did that work? I think that's also very helpful. So you don't try to repeat treatments that have already been done that didn't work the first time. And also any complications from other treatments is very important to know, specifically like a contralateral recurrent laryngeal nerve injury or something that could cause additional morbidity if you engage in additional treatment. For ultrasound and FNA, we think about looking for meaningful disease. So that means that the lymph node that we are focusing on in the neck that we think might be cancer, might not, we're not sure. We're thinking about doing a biopsy. It shouldn't be a 2, 3, 4 millimeter lymph node. It needs to be greater than about 8 to 10 millimeters in its smallest dimension. Then it might qualify for an FNA with thyroglobulin measurement. If it's smaller than that, probably we're going to watch that without biopsy. And if there's growth, then that's something that we would go after. But if it's very small, it's going to be impossible to find in the operating room. And it's questionable whether it's even clinically relevant. How you treat thyroid cancer has got the same exact considerations that I showed before, whether or not you treat it. The preferred treatment based on multiple expert guidelines is surgery if it can be identified and resectable, identified and is determined to be resectable. In general, all those other therapies that are available are not as good as surgery. So if you have resectable recurrence, you should almost certainly resect it as long as it's possible to do so and it's safe to do so. For papillary follicular and oncocytic carcinomas, this is what the NCCN guidelines look like. Recurrence is treated differently depending on whether it's local, regional, metastatic, or if we have no idea where it's coming from. I put this slide up there just to kind of show you in general what the process is, but there's way too many words on here to try to read this. But I'm going to focus your attention to where I put the red circle down here. Now what we're starting to see in expert guidelines is that they're starting to introduce the possibility of using percutaneous ablation techniques like ethanol or radiofrequency ablation. And we're starting to see that for local, regional recurrence and metastatic disease. So start to look for that being more and more fleshed out in the next few iterations. This is how I just recreate that slide. Again, for local recurrence, usually you biopsy to confirm you're dealing with a recurrence and it's not scar tissue, and surgery is where you go next. If it's not something you can operate on, you ask questions like, should we do radioiodine ablation or external beam? And then usually at the bottom of the list is systemic therapy or watchful waiting. But you see I've placed a couple arrows in here where I think things are moving. I think that systemic therapies and experimental trials are going to leapfrog over external beam radiation because of the morbidity of external beam. And I think that watchful waiting and maybe RFA and ethanol are going to pop in somewhere around surgery. And it may be that it's something that's done instead of surgery, or it may be if it's like equivalent, you could do surgery or you could do RFA. Some people would maybe lean towards RFA depending on the location of it. So I think we're going to see some of these percutaneous things leapfrog up in the algorithm over the next 5 years. Right now, we're not doing a lot of RFA for cancers, but it is starting to become more common. Systemic therapy options have also gotten better over the last 5 or 10 years. And so we have a number of drugs that I've listed here that are available to use. Specifically, we've got a couple of designer drugs that, for example, target in RTK or RET fusion, for example. All the things to know about these systemic drugs is that they're not really for stable disease or slowly progressive disease that's indolent. They're usually reserved for more aggressive diseases because the treatment is not without side effects. Regional recurrence, again, we do an FNA, usually formal compartmental clearance. And if radioiodine hasn't been done in the past, that's something that they consider, and directed therapy is what I was talking about when I said RFA and ethanol. For the lung, some people are looking at RFA for this as well, but most of the time when you have metastases in the lung, it's micrometastatic, so there isn't like a big thing that you can go after, so radioiodine is more common treatment. If it's a big thing, that's surgery or maybe a directed therapy, and systemic therapy is available with the agents that I've listed here. Bone can also be treated with RFA, but I think that the key is there's a lot of pain and there's instability. So external beam radiation is a common treatment to try to stabilize it and reduce pain. Some of them will be radioiodine avided. Some of them should be resected. And bisphosphonates are helpful for strengthening the bone as well. Brain's usually resection or gamma knife. You would think that that would be the one that maybe was done systemically, but actually what's been shown is a better idea to do surgical resection for that. Recurrent medullary cancer, again, there's a big algorithm in NCCN. Essentially what it boils down to is if it's resectable, you do surgery. There are now systemic therapies that are available that you can choose for people with larger volume disease. It's rapidly progressive. And then it boils down to this, just to make it simpler to read. For local regional recurrence of medullary, so that's in the neck somewhere, surgery is the preferred treatment. You can consider external beam radiation or systemic therapies. For distant disease, again, like in the liver, for example, directed therapy or resection. And then the systemic therapies are listed here, and there's very specific ones that are available for specific mutations that can be very helpful in individual cases. For progressive disease, again, the same systemic therapies. If they don't work, then we're kind of going back to the chemotherapy protocols that we used in the past, external beam, bisphosphonates or denosumab, and then palliative resection or ablation in some cases. So what are the limitations of screening? Just to recap everything that I showed you earlier, physical exam is not very sensitive. Ultrasound can miss some deep nodes or those that are behind the airway. Blood tests are great, but there are some patients that have interfering antibodies. So about 20 to 25% of all papillary cancer patients have anti-thyroglobulin antibodies that interfere with our ability to measure thyroglobulin. And there's also some cancers that just don't make the tumor markers anymore. And the tumor markers are no longer helpful. One thing to remember is that a lot more patients are getting lobectomy now than ever before, and patients with lobectomy will always have a positive TG. So we're really not able to rely upon thyroglobulin as a tumor marker for recurrence in those patients. Radioiodine scans had been done so much in the past, but some cancers lose their appetite for iodine, don't show up on those scans. And patients who've had a lobectomy should not be getting radioiodine scans because all the radioiodine goes to the thyroid gland. It doesn't help you. PET scans have always been, I've always thought of them as being very good for poorly differentiated cancers or those patients that have radioiodine negative thyroglobulin positive cancers. But the reason that we didn't recommend it for everything is that they're not always sensitive for those well-differentiated cancers. Some people will have a well-differentiated papillary and won't show up on a PET. But I think what we're finding more and more is the PET scans are actually more useful than we thought they were. So I'm seeing more patients who are getting them. And DOTATATE scans, as I showed you on the on that one slide with the rotating images, are really excellent, but they're not widely available. So not every place has DOTATATE scanning, and they're also fairly expensive. Prevention of recurrence is kind of the holy grail. Probably the best advice is early diagnosis and treatment of the primary cancer, because the bigger the cancer is at time diagnosis, the greater the chance of recurrence. The more lymph nodes you have, the greater chance of recurrence. The less complete resection you have, the greater chance of recurrence. So find it earlier and you're going to have a lower recurrence rate. Complete removal of the cancer, the first operation, is also important, and appropriate lymph node clearance. I see a lot of patients who have had a thyroidectomy with no lymph nodes removed, and they have a number of lymph nodes that have been in their neck for many years, and they are not really a recurrence. They were always there probably. If they were taken out the first time when they were clinically positive, then they wouldn't be there. So I think we do a lot of things prior to surgery, like screening and mapping ultrasounds of the lateral neck and central compartment to know what's there. Because if there's already cancer spread in the nodes, let's take care of them all at once during the first surgery. Radioiodine should be used in high-risk patients, of course, not MTC, and TSH suppression for most patients. I'm not aware of any diet, exercise, detox, homeopathic, or holistic approach that prevents or treats thyroid cancer. So just be aware of that. And I think that concludes the presentation. I got there 2 minutes before the end. I thank you for allowing me to give this talk to you today.
But Dr. Sturgeon, I appreciate you taking the time to do this talk. And yeah, appreciate everyone coming.
Yeah, my pleasure.
Thank you so much.